defined as a waveform which is felt by the finger against the bony prominence produced by the cardiac systole, or produced by the cardiac systole, which is traverses the arterial tree in a peripheral direction, which is at a rate much faster than the blood column of the blood. It is felt against the peripheral artery, against the bony prominences. It is commonly seen in the palpated with the radial artery with the use of the three fingers. In pulse, we have to see the rate of the pulse, rhythm of the pulse, force, volume, and tension of the pulse, character of the pulse. Then, is there any apex pulse deficit? If there any condition of the arterial wall, radio-radial, radio-femoral delay, and if there is bilateral symmetrical or not, we have to check all of these in the pulse rate. Normal rate of the pulse is around the 60 to the 100 per the 60. It is counted for the fully 1 minute by the palpebral radial artery. Normal rate is around the 60 to the 100 per the minute. If it is less than 60, then it is called bradycardia. If it is more than 100, then it is called the tachycardia. If it is less than 100, it is commonly seen in the athletes. It is seen in the sleep also. In pathological, if patient has a severe hypoxia, or patient has a obstructive jaundice, or patient is on the beta blockers like the drug, or patient is on the digoxin or verapamil drugs, heart block, raised intracranial tension, hypothermia, and hypothyroidism or mixed edema. These are the common causes of the bradycardia. One is, if it is more than 100, then it is called as the tachycardia. The causes of the tachycardia are the anxiety, stress, alcohol in infants, in children, and in the pregnancy. Some pathological causes of tachycardia like the cardiac failure, tachyarrhythmias, high output stress like the severe anemia, thyrotoxicosis, Paget disease of the bone, AV fistula, or patient is on the like a beta-2 agonist like salbutamol, or patient is on the nifedipine, or patient is on nicotine or caffeine. In fever, in the relation between pulse and temperature is there. For every 1 degree rise in the temperature, pulse is generally rise around the 10 mm of Hg. If it is less than 10, then it is called as the relative bradycardia. It is seen generally in the enteric fever. After rate, we can check at the rhythm of the pulse, whether a patient has a normal sinus rhythm or some abnormal rhythm. In young patients, respiratory variations of the rhythm is generally seen. It is known as the sinus arrhythmia. It is generally normal. Another is the regularly irregular rhythm and the irregularly irregular rhythm. Both are the abnormal. Regularly irregular rhythms are atrial tachyarrhythmias with a fixed AV block, or in the ventricular bigeminy or the trigeminy. Or second one is the irregularly irregular. It is commonly seen in the atrial fibrillations. Or in the atrial flutter with the variable atrioventricular blocks, or sometimes in the ventricular or atrial ectopics. Now we will go to the volume of the pulse. Volume of the pulse is best assessed by the palpating the carotid arteries. It is the pulse pressure, difference between the systolic blood pressure and the diastolic blood pressure, which gives the accurate measurement of the pulse volume. Normally, it is between the 30 to the 60 mm of the Hg. But if it is less than 30 mm of Hg, then it is called the hypokinetic pulse. If it is more than 60 mm of Hg, then it is called as the hyperkinetic pulse. Hypokinetic pulse is generally seen in the hypovolemia, hypotension, shock, mitral stenosis, or an aortic stenosis. Increased volume of the pulse is generally physiologically seen in the fever, pregnancy, alcoholism, and exercise. And pathological like the high output cardiac stress like the severe anemia, beriberi, thyrotoxicosis, and AV fistula. Some abnormal type of the pulse we can see that one is the pulsus parvus at the tardus. It is a slow rising with a late peak condition. It is generally seen in the aortic stenosis. Another is the water hammer pulse, which is generally seen into the aortic regurgitation or suddenly some high output status. Like it is a large volume pulse, there is a sharp rise in the volume, so systolic pressure is high and then sudden fall. Diastolic pressure is the very low. So pulse pressure is more than 60 mm of Hg. It is seen into the aortic regurgitation, patent ductus arteriosus, and AV fistula. For water hammer pulse, we have to hold hand like this and raise the above the level of the arm. So fall we can exaggerate and we can demonstrate the water hammer pulse like this and hold finger like this. Another is the pulsus bisperans, which is a two peak in the systole, which is seen in the severe aortic regurgitation. Second one is the pulsus dicroticus. It is one peak in the systole and another in the diastole, which is seen in the typhoid fever and left ventricular fever. One other is the pulsus alternans. When there is an alternating small and the large volume pulse seen in the regular rhythm, it is seen in the left ventricular fever because some fibers are functioning not regularly. So the alternate large and the small volume pulse is seen in the pulsus alternans. Another one is the apex pulse. Now we will see the apex pulse deficit. What is the apex pulse deficit? We have to measure the heart rate and the pulse rate simultaneously fully for the 1 minute. Either by single examiner or with the two examiner. If single examiner we are doing simultaneously, then we have to just count the miss bit. If two we can, if it is more than 10 per minute, then it is significant apex beat and it is called as it is found in the atrial fibrillation. If it is less than 10 per minute, then it is seen in the ventricular premature contractions. Like this is in this figure, one examiner is auscultating and another is the palpating. So what is the difference between them? We can count them, and it is seen into the atrial fibrillation. And if it is more than 10, it is significant. Now we will go to the asymmetry of the pulse. Asymmetry of the pulse is generally seen in the coarctation of aorta, embolism, thoracic outlet syndrome or scalenus anticus syndrome or any peripheral vascular disease. These are the abnormalities of the pulse. So in pulse we have to check that whether it is 80 per minute with the normal force, volume, tension, with normal condition of the arterial wall, with the apex pulse deficit, with radio-radial, radio-femoral delay. You have to check all these. Now we will check for in the general examination after pulse we have to see for the peripheral signs of the aortic regurgitation in a case of the valvular heart disease. From what are the peripheral signs of the aortic regurgitation? It are from head to toe. First is the lighthouse and alternate flushing and the blanching of the forehead seen in the aortic regurgitation. Second one is the Landolfi sign in the change in the size. Third one is the Demoset sign, bobbing of the head, which is start of the each heartbeat. Fourth one is the capillary pulsations of uvula, systolic pulsations of uvula, and next one is the capillary pulsations. Another sign is the corricant pulse, like the water hammer pulse we have also seen. And last is the Durosis murmur. When we put the stethoscope over the femoral artery, when compressed proximally, diastolic murmur, systolic murmur is heard, and when we compress distally, diastolic murmur is the heard. Trop sign is the piston sound over the femoral artery. Now we will go to the another is the Hill sign. In the Hill sign. Normally in the lower limb blood pressure is more than 20 up to 20 mm of Hg, then the upper limb in normal person. But if it is more than 20 mm of Hg in a cases of the aortic regurgitation, by this way we can classify the severity of the aortic regurgitation. If it is more than 20 mm of Hg, then it is the mild aortic regurgitation. If it is more than 40 mm of Hg, then it is moderate aortic regurgitation. And if it is more than 60 mm of Hg, then it is the severe aortic regurgitation. In AR, the pulsations of the liver and spleen also seen. After peripheral signs of AR, we can check for the jugular venous pressure. Jugular venous pressure or pulsation. Jugular venous pressure is measures the pressure in the right atrium. When pressure is in the right atrium, JVP is also increases. Increased JVP causes are the heart failure, fluid overload, and constrictive pericarditis. We have to differentiate these from the carotid pulsations. How we can differentiate it from the carotid artery pulsations? So jugular pulsations are better visible than palpable. Carotid pulsations are better palpable. Jugular pulsations have a 2 peak per the heartbeat. Carotid pulsations have a 1 peak per the heartbeat. Jugular pulsations are obliterable, while carotid pulsations are not obliterable. Jugular pulsation has a variation with the posture and the respiration, while the carotid pulsation has a no variation with the respiration and the position. What now in the JVP there is a Kusumal signs when during inspiration JVP normally during inspiration JVP falls, but in a condition of pericardial effusion or constrictive pericarditis JVP remain prominent during the inspiration. How we will check the JVP? For JVP, we have to check like patient in the 45-degree position with the bed. A bed is not available, so put the patient on the elbow support and the 45-degree head we have to put. Move head to the opposite side toward the left side, and one measure the sternal at the one hand at the sternal angle, and we have to vertically measure the pulsation in the neck from sternal angle by in the centimeter of the water. If it is more than 4 mm of Hg from the sternal angle, then it is the raised JVP is called. Waves of the JVP are the A, C and the V wave, and X and the Y descents are there. A wave is due to the right atrial contraction. C wave is due to the ventricular contraction, right tricuspid valve ascents. X descent is due to the right atrial relaxation. V wave is due to the passive filling of the endoatrium. Y descent is the atrial emptying with the opening of the tricuspid valve. So A wave is due to the atrial contraction, it is absent into the atrial fibrillation. Large A waves are seen into the tricuspid stenosis and the right ventricular hypertrophy. Cannon shape A waves are seen in the complete heart block. Now we have to show the abdominal jugular reflex or hepatojugular reflex. It is when we are compressing the right paramedical area or the right upper part of the abdomen. Normally JVP rises less than 3 cm, and after that later on it falls even if we continue the pressure. But in a patient with the right heart failure, there is a persistent elevations of the JVP. It is called as a abdominal jugular reflex. By this way we can check the abdominal jugular reflex. These are the general examination. After that, we have to check for the inspection. For inspection, shape of the chest, precordium, apex impulse, pulsations over the precordium, pulsations in the neck like the suprasternal, supraclavicular pulsation, any scar, sinuses, dilated veins on the precordium, and the back and the spine abnormalities we have to check. Apex impulse is best seen by the tangentially inspection of the chest wall in a good light with patient lying down or sitting up or slightly forward. It is located into the left fifth intercostal space. We will detail describe into the palpation. By this way we can check the apex impulse. It is sometimes absent, non-visible or non-visible apex impulse can be seen in patient with the dextrocardia, or if it is behind the rib, or patient is obese, or patient has a COPD, or female patient. If it is behind the rib, if patient is supine, we can do the sitting position and we can check for the apex impulse. Now precordium. What is a precordium? Precordium is the area of the anterior aspect of the chest wall overlying the heart. Precordial bulge indicates the presence of the right ventricular hypertrophy early in the childhood before the epiphyseal fusion. Now we have to check for the any pulsations over the precordium, visible pulsations of the precordium. The visible pulsations over carotid artery is seen in the aortic stenosis, aortic regurgitation, chaotic coactations of aorta, or pulsations in the suprasternal or the supraclavicular like aortic aneurysm and aortic regurgitation. And epigastric pulsations are seen in the aortic aneurysm or aortic regurgitation. These are the points in the inspection. Suppose if a patient, you can speak like this, apex impulse is palpable. Suppose a patient of mitral stenosis, you can speak like this, apex impulse is palpable in the left hip, visible in the left hip intercostal space, just medial to mid clavicular line. It is 10 centimeter lateral to the mid sternal line. Precordium is the normal. There are no visible pulsations, over the chest wall or over the precordium. There are no scar, sinuses or dilated veins seen on the precordium, and back and spine is normal. Now on palpation, we confirm the inspectory findings. Let's come after that. We have to palpation of the chest. Palpation first is the apex beat, second one is pulsations of the abnormal side, third one is the thrill, fourth one is parasternal heave, any palpable heart sound, carotid artery palpation, and tracheal tuft. Now we discuss for palpation, any heart sound and any palpable pulsations are palpated with the tip of the fingers. Thrills are palpated with the base of the fingers, and the parasternal heaves are palpated with the base of the hands. Apex impulse. Apex impulse is the lowermost and outermost point of the definite cardiac impulse with a maximum perpendicular thrust to the palpating finger. It is caused by the left ventricle or the left ventricular portion of the interventricular septum. It is just medial to the midclavicular line and 10 cm lateral to the midsternal line. Normal apex impulse confined to the one intercostal space and around the 2 to 2.5 centimeter areas. Normal duration of apex impulse is less than 1/3 of the systole. If it is not visible, we have to check for the dextrocardia or any other. By this way, we can palpate the apex impulse first, and second one we have to locate with the index finger. Apex impulse. There are some abnormalities of the apex impulse are also. One is the tapping apex beat. Tapping apex character of the apex impulse is best studied in the left lateral position. Another abnormalities of apex impulse like the tapping apex impulse. Tapping apex impulse means it is a palpable first heart sound. It is seen in the mitral stenosis. Another one is the hyperdynamic apex impulse. It is increase in the amplitude without increase in the duration. It is due to the volume override conditions like aortic regurgitation and hyperdynamic circulation. Third one is the heaving type of the apex beat. It is seen in the pressure overload like conditions like the increase in the amplitude and the increase in the duration. It is seen in the aortic stenosis. After apex impulse, we have to check for the thrills. What is the thrill? Thrill are the palpatory murmur or vibratory sensations feel to the palpating hands when your hand is put like on the back of the cat. Presence of thrill indicates that the murmur is the organic and the grade 4 or the more. Systolic thrills are found in systolic thrills are found in the aortic stenosis or aortic area and mitral regurgitation over the mitral area, and diastolic thrills are found in the mitral stenosis into the apex. If thrill is present, then murmur is the organic and grade 4 of the death. Now we will check for the parasternal heave. It is a palpable thrust which lifts the palpating head seen in the right ventricular hypertrophy and the left atrial enlargement. It is palpated by the ulnar border of my hand like this also. It can be graded by the Ames grading. It is visible, but grade 1 is visible but not palpable. Grade 2 is visible, palpable and can be obliterated. Grade 3 is visible, palpable and not obliterated. This is like a peristernal heave can be palpated like this. It is seen in mitral stenosis of patient with the patients with the right ventricular hypertrophy. After that, we have to check for the palpable heart sounds. Palpable heart sounds are palpable with the tip of the fingers. In case of mitral stenosis, first heart sound is loud, loud and it is loud and palpable. So it is palpated at the apex. In second heart sound, pulmonary hypertension, second heart sound is palpable at the pulmonary. P2 component of second heart sound is palpated at the pulmonary area. It is called at the diastolic shock. And S3, S4 and opening snap are also palpable. What is the mechanism of the loud S1 in the mitral stenosis? Due to the mitral stenosis, there is a calcification and fibrosis of mitral valve commissures and mitral valve leaflets. So the mitral valve leaflets are thickened and there is a transmitral gradient. So pressure between the left atrial to left ventricle is high. So mitral valve is open till the late diastole before earling of the systole. So sudden closure of the thick mitral valve causes the loud S1. If it is in some cases of mitral stenosis, loud S1 is not there, like associated mitral regurgitation is there, or if patient develops atrial fibrillation, the first sound becomes the variable. Or patient's leaflets are not mobile, so it cannot move. So in this condition, first sound cannot be loud. Other we can palpate like ejection click, gallop sound, pericardial knock sound, or vibrations provoked by prosthetic valves. And palpable friction lobes. So in palpation, suppose if patient of mitral stenosis, we can speak like this. I have confirmed my inspectory findings. Apex impulse is palpated into left fifth intercostal space, tapping in character. It is 80 per minute, regular in nature, just medial to the mid-clavicular line with just medial to the mid-clavicular lines. There is no visible pulsations over the, no palpable pulsations over the precordium. There is a no thrill and peristernal heave is present in the left middle area. After we go to the percussion, significance of percussion is only for the for most common is the pericardial effusion, to rule out pericardial effusion. Percussion of the heart border, right heart border. How will you percuss the right heart border? So first mark the sternal angle, go to the mid clavicular line. From about to downward, we percuss the lever in the fifth intercostal space. Go one intercostal space above and palpate from percuss from mid clavicular line to the right sternal border and go repeat similarly into the other two intercostal space. Normally, right heart border is behind the sternal. Dullness correspond to the right sternal margin is the normal. Dullness outside the right sternal margin is seen in the right ventricular hypertrophy or right atrial enlargement. Left heart border. Left heart border, for percussion of the left heart border, we have to, for left heart border, we have to palpate apex and one intercostal space for outward and start from the mid axillary line and start percussing medially. Direction of percussion should be parallel to the left heart border. Normally, it corresponds to the apex. Dullness outside the apex is seen into the pericardial effusion. This is the percussion. So in percussion, you can speak the left heart border is coincide with the apex and the right heart border is behind the sternum or it is outside, so you can say outside. Now auscultation, most difficult part of the cardiac auscultation. How will you auscultate? So for which we use the bell of the stethoscope and for which we use the diaphragm of the stethoscope. Bell of the stethoscope is used for the low pitch sounds and for high pitch sounds. Low pitch sounds like the mid diastolic murmur of the mitral stenosis and S3, S4 low bell is used and first and second heart sound and the other murmurs diaphragm of the stethoscope is used. Which area we can auscultate? First we auscultate like the mitral area, or apex with the left fifth intercostal space in the mid-clavicular line. Second one is the tricuspid area, fourth left intercostal space, lower sternal border. Third one is the pulmonary area, second left intercostal space, and the fourth one is the aortic area, right second intercostal space, and fifth one is the orbs area, left third intercostal space, left sternal border. Difference between the aortic area and the orbs area is that the orbs area regurgitation murmurs of the aortic rheumatic valve are better heard at the orbs area. This area we have to auscultate, above this we have to auscultate the carotid, suprasternal, axillary area. What we hear in the auscultation? First, for the heart sound. In the heart sound, lub and the dub is heard. So lub is the first heart sound, dub is the second heart sound. First heart sound is primary because of the closing of the mitral and tricuspid valves. Anatomically, they close because the ventricles contract. The loud first heart sound is seen in mitral stenosis, diminished in the mitral regurgitation. Second heart sound, it is a dub in the lub and dub, and sounds are because of the closure of the pulmonary valves, and this is the end of the systoles. By the correlating with the first and second heart sound, we can mark the systole and the diastole, and we can confirm the murmur whether it is a systolic or the diastolic murmur. Wide split second heart sounds are seen in the atrial septal defect, right bundle branch block, or pulmonary stenosis. Loud P2 is found in the pulmonary hypertension, like diastolic stroke. Systole. Time between the first and second heart sound is called the systole. During this time, ventricle contracts, blood flows from the heart to the lungs and the body, and blood flowing across the pulmonary and the aortic valves. Murmur found during this first and second heart sound are the systolic murmur. Diastole. Time between second and the fourth heart sound is called diastole, and blood flowing from atria to the ventricle, blood flowing across the bicuspid and the tricuspid valves. Now the third heart sound, it is S3 is a protodiastolic gallop or ventricular gallop. It is normally seen into the youth and the young adults, and sometimes seen in the left ventricular failure. Fourth heart sound is due to the presystolic gallop or atrial gallop. It is formed by the sound of the blood forced by the rapid atrial filling into the non-compliance ventricle. Now we will check for the heart murmurs. Heart murmurs are abnormal sound caused by turbulent flow into the heart and the great vessels. How will you, if some murmur is found, what are findings you have to see? So these are the timing of the murmur, whether it is the systolic murmur, diastolic murmur, mid diastolic murmur, early systolic murmur, location, where it is heard at the loud, aortic area, pulmonary area, tricuspid area or mitral area, whether it is localized or radiated. Like the murmur of the mitral regurgitation radiates to the axilla, murmur of the aortic stenosis radiates to the carotid. Intensity, grading of the murmur, it is grade 1 to grade 6. Pitch, like the high pitch murmur is high pitch or low pitch, like a murmur of the regurgitant murmur are the high pitch and the stenotic murmur are the low pitch. Quality of the murmur, like the murmur of mitral stenosis is the rumbling in the character. Shape of the murmur, whether it is a crescendo, decrescendo, or whether it change with the expirations. These are the different types of the murmur. You can say. Quality of the murmur, like the in mitral stenosis you will get the rumbling character of murmur. In patent ductus arteriosus you will see the continuous machinery type of the murmur is the set. Low pitch murmur is found in the mitral stenosis, and the high pitch murmur found in the aortic regurgitation and mitral regurgitation. How will you differentiate the functional murmur from the organic murmur? So functional murmur are caused by the hyperdynamic circulation, fever, anemia and thyroid. Okay. Functional murmur are never associated with the thrills. Functional murmur are never radiate or conduction is the poor, and when cause is removed, functional murmur is disappears or diminishes. These points we have to check in the cases of the murmur. Now we will describe the murmur of the mitral stenosis. What is the murmur of the mitral stenosis? It is a low pitch rumbling murmur, mid diastolic murmur, base heard at the apex, base heard with the left lateral position. It is associated with the pre-systolic accentuation and base heard with the at the end of the expirations. We can discuss. This is the mid diastolic murmur, well located at the mitral area. Other murmur at the mitral area, mid diastolic murmur at the mitral area are the Austen-Fleet murmur, and the second one is the Carey-Combs murmur. Austen-Fleet murmur is murmur seen in the aortic regurgitation, and the Carey-Combs murmur is seen in the acute rheumatic fever, is found at the apex. Other now we go to the murmur of, in MR we can get the pansystolic murmur at the mitral area. This comes to the auscultation. Now how will you speak in the auscultation? So first we describe, go to the one valve. First is the mitral valve. Then where go the first sound is loud. Second out sound is normal, S3, S4 is not heard. Now if there is no extra sounds and the murmur, if there is a murmur, then you have to describe the murmur. After that you have to go to the other area like tricuspid area with their first out sound, second out sound. If any extra sound is heard out that, any murmur is there, then go to the aortic area and then go to the pulmonary area. By this way you can describe all four areas. First heart sound, then a murmur and then any extra sounds. By this way you can shortly describe like the systolic murmur are present in the aortic stenosis, mitral regurgitation, tricuspid regurgitation, and diastolic murmur are aortic regurgitation and mitral stenosis. In mitral stenosis you will get a loud S1. Now we shortly see the mitral stenosis. Mitral stenosis is predominantly caused by the history of the rheumatic fever, past history of rheumatic fever. Rarely it is congenital or some other causes like the in the SLE and RA. Normal mitral valve area is the 4 to 6 centimeter square. If it is 1.5 to 2.5 centimeter square, then it is called mild mitral stenosis. If it is 1 to 1.5 centimeter square, then it is moderate mitral stenosis. And if it is less than 1 centimeter square, then it is called severe mitral stenosis. Patient may have a complaint like fatigue, palpitation, cough, orthopnea, PND, palpitation, or sometimes symptoms of the embolizations. And in ECG, you will get P mitrally, right ventricle hypertrophy, and atrial fibrillation. On X-ray, you can say the left atrial enlargement, double straightening of the left heart border, and the double cardiac shadow and mitral valve calcification. Okay, thank you. Okay. बंद कर दो, बंद कर दो.
हमारे पहला लेवल છે તો ઇન્ટ્રોડક્શન કે ચાલુ કરી દઉં?
હા ચાલુ કર દો મેડમ, તમારું ઇન્ટ્રોડક્શન આપી દો ખાલી.
તમે બોલો કે હું બોલું?
બોલી તો એક જ મિનિટ, તમારું ઇન્ટ્રોડક્શન આપી દો ખાલી.
ચાલુ કર દો.
હેલો હેલો.
So it's a late good morning. You may be exhausted with the learning of CVS system. Again, little bit difficult part is coming. In your short case, one short case is of neurological examination, and our Dr. Sonali madam is going to take neurological system examination first. So try to concentrate. Okay, it's a revision. So most of the you I suppose that you have read from the books. So from when the exams are going to start? 6. So just day after tomorrow. Okay. Best of luck.
So, welcoming Dr. Solani Mehta, Assistant Professor, Medicine Department, Narendra Modi Medical College. She is member of CBME Curriculum Committee and she is MD Medicine from BJ Medical College and she is going to take CNS short case. Thank you. Welcome, madam.
Good morning. I'll be just briefing you with short case CNS2, 4 parts as you all remember. I hope you remember. Motor, sensory, reflexes, cranial nerve. I will be briefing you only of the examination points, what the examiner expects from you in the answer format, and the questions regarding the same topics, right? And in the end, I'm going to show a video, so don't panic. It is not just a theoretical presentation, right? Okay. And I expect silence in the entire lecture. Don't talk amongst yourself. Yes. So first we'll take motor. Motor examination always includes, for any examination in the CNS will include inspection. You just don't start touching the patient immediately. Inspection part will have nutrition and decubitus, right? Then tone, power, coordination, gait and involuntary movements. These are the main headings under which we have to examine motor system. Nutrition. Nutrition is the girth of the limbs you measure. So the points you have to measure 10 centimeter above and below olecranon in upper limb, 18 centimeter above superior border of patella and 10 centimeter below tibial tuberosity in lower limb. Any difference of more than 1 centimeter is abnormal, right? More than 2 centimeter. And palpation of the muscles also you have to see whether it is flabby, whether it is firm, very compact type of muscle. It will be normal always, but when the pathology is present, hypotonic, atrophic muscles will be flabby and hypertrophied muscles will be firm. Other parts you have to examine or inspect in things is wasting of hand, atrophy, hypertrophy, pseudo-hypertrophy, anywhere in the entire body. You should know how to see for it, right? Decubitus is usual position of the patient, like hemiplegic patient or comatose patient or decerebrate rigidity, decorticate rigidity, that on inspection sometimes you can appreciate. Then comes tone. Tone is physiological state of tension in the resting muscles and it is always examined by passive movement, no active movements, right? So that also in inspection you can see sometimes visible hypotonia na karane je positions we get in the limbs, like shoulder, if it is atrophied, there will be drooping of shoulders, right? Sometimes some muscle groups will be visibly by inspection only. Then palpation, as I said before, flabby or compact. Passive movements, I am focused on that, insisted, it is always done in passive. Dangling methods for wrist and ankles. right? Then the questions, they expect the causes of hypertonia, types of hypertonicity, spasticity, rigidity. One of and these in this you will also be asked signs of extra-abdominal lesion, so you should be knowing it, right? Rigidity types, cogwheel, lead pipe, decorticate, decerebrate, and hysterical. Clonus, myotonia. How to examine clonus? You have to know ankle clonus and patellar clonus, right? Ankle clonus, semiflexed hip, semiflexed knee, and push on the ankle. Okay, and patellar clonus, just in the supine position, completely supine leg, push on the patella, superior border, and lift it back. So you will feel the sustained clonosis. Sustained, ill sustained definitions you have to know. More than equal to 5 oscillations of the limb is sustained. Myotonia. There are various types of myotonia. What is myotonia and causes of myotonia? That you should know. Then power. Power, when you begin, start from head to toe. So neck, upper limbs, abdominal muscles, hips, knees, and lower limbs completely, right? And you have to measure at every joint, in every movement of that joint. Like shoulder is abduction, adduction, flexion, extension, and circumduction, rotation, right? Power, for power you have to first, any group of muscle if you are testing, don't apply resistance first. Ask patient to normally abduct the shoulder, right? Done. Then apply some resistance, then full resistance. If patient is not even able to do with normal movements, like without any resistance, I am not able to lift this, so I am not even able to lift it against gravity. So now you have to check for the power 2. The power is already less than 3. That means that if I am able to do this, means power is 3. So now resistance 4, 4 minus 4, 4 plus, and full resistance 5. So if I am able to do this, I am going to have power more than 3. If I am not even able to lift this, it is going to less than 3. Then you have to eliminate gravity. You have always to differentiate between 3 and 2. So at all groups of muscles, at all movements of joints, you have to know how to eliminate gravity, right? Oh. And those methods are given in all your books. You are already used to seeing videos, so you have the resources, right? Grading, just note down, it is given in every book, same. What is 4 minus 4 and 4 plus? It is 1 finger, 2, 3 finger and 5 finger. And 5 is full resistance, whole palm, whole hand, right? So 4 minus 4 and 4 plus. Coordination. All the tests you know. Outstretched pronated arms, you have to see for drifts or any other pronator drift or parietal drift. Then finger, nose, finger, 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 nose, finger. In upper limbs, heel, knee test. In lower limbs. Barabar? Okay. Then dysmetria, dyssynergia. Dysmetria, dyssynergia definitions, what you mean by it and how you will see. Barabar? The dyssynergia and dysmetria is seen in when it can be noted when patient has it. It can be noted when you are doing finger, nose, finger, finger and finger, nose, finger test. You will be able to see it in those signs only, right? Then dysdiadochokinesia, alternate tapping movements we are doing on both hands. And yes, one thing, whenever you start motor examination, do it symmetrically bilateral sides. You are checking power of one shoulder, then check power of the second shoulder on the left side. Right, left, go from head to toe, everything, right? Rebound phenomenon, pass pointing. Definitions, what do you mean by that? And you may be asked to imitate the same, right? So you should know how to show what is rebound phenomenon. Gait, different types of gaits. Many types of gaits are there when you try to learn CNS in detail. But for you, these are the few: circumduction, Parkinsonism, ataxic, high steppage, seizure, waddling, limping, right? You should know how to imitate them. We don't expect that much from you in MBBS level, but you should know how to imitate them because patients will not have all the gait. Motor, involuntary movements. Tremors, convulsions, chorea, athetosis, dystonia, hemibellismus, fasciculation and tics. Know the definitions and the causes. Usually examination mein you don't get such kind of involuntary movement cases, right? Now reflexes, you should know the definition. Reflex pathway or reflex arc of each reflex you are going to perform, right? Examiner usually asks as a leading question only, perform this reflex or perform biceps, perform triceps, whatever. So interpretation, you should know what is the changes in CNS when in UMN lesion and LMN lesion. So LMN lesion, below the level of lesion, all reflex is lost, superficial and deep. In UMN, superficial reflex is lost, deep tendon reflex is exaggerated with extensor plantar below the level of lesion, right? Grading of the response is done like this: 0 plus, double plus, triple, and 4 pluses. So absent, diminished, normal, exaggerated, and brisk. So normal is +2. Any brisk is +3. And +4 is clonus. Usually you don't get examination as a clonus, but perform the how to look for clonus, you should know, I told you, right? Then reflexes, if you are asked, perform reflexes of the entire body, then you have to start from head to toe. First superficial, then deep, then other visceral and primitive reflexes are always absent. You don't get such cases in your exam. So superficial are corneal, conjunctival, pharyngeal, palatal, scapular, abdominal, cremasteric, plantar. Important for you: corneal, conjunctival, abdominal, plantar, right? Abdominal, you have to go from outside to inside towards the center and centrifugal, right? So if this is my abdomen, 1, 2, and 3, right? Along the inguinal, along the hypochondriac line, and in the midline horizontally. And you should know the clinical importance. If it is absent in one side, it is, what is the cause? Any hemiplegic stroke, superficial reflexes will be absent on one side. And if there is a spinal level lesion below T10, below T6, so below all those lesions, lost. If T10 is important, we say it Beaver sign, right? So that is important. It is usually frequently asked in your exams. Plantar method, proper method. Touch from the here lateral aspect of the sole to the thumb, this side, right? Base of the thumb. Babinski sign you should know. Other methods and plantar equivalents. Plantar equivalents in upper limb, at least name and a examination method. This is Wartenberg, and by fixing here, you have to fix this in your patient's finger and flicker this. This is Hoffman. This is Hoffman. Deep tendon, jaw jerk, trapezius, pectoral, biceps, triceps. Supinators, finger flexion, knee jerk, ankle jerk. All this I will be demonstrating in the video, but important part, know the root value of all the reflexes. If you do not know the root value, you will not get the minimum marks also. Clonus, as I said before. Then some questions, credit questions, inverted reflexes and what is their importance. Every reflex can be inverted. Inverted means not the routine response, the inverted response. Like flexor, bicep should flex, it extends. That is the inverted. Primitive reflexes, some names and methods you should know. Grass knucking snout, glabeller, mass reflex, tonic neph reflex. Mass reflex is asked as a question sometimes, you should know. And what is the cause also you should know, right? Abnormal deep tendon reflexes and their interpretation, yes, you have to know. This is the difference in weakness, tone, reflexes, abdominal, right? This table is given in every book. Every book you open, this table will be given. Cranial nerves. Okay, we start with cranial nerves. Pure sensory 1, 2, 8, motor 3, 6, 3, 4, 6, 11, 12, and mixed 5, 7, 9, 10. Right? Cranial nerve 1, olfactory. You keep some smelling of things in your kit. These are the example. Test each nostril separately. Cranial nerve 2 is important. Parts of examination, points of examination in optic nerve is acuity, visual fields, color vision, fundus, and optic nerve head. That is, you have to have fundoscope. We do not expect to, but usually you have to have one fundoscope. Common fundoscope is okay. Color vision, Ishihara chart, visual fields, bedside visual field testing. That is usually asked in your exams. Confrontation test and red pin test. Confrontation test, 1 arm length, you keep the patient, test the fields by bringing your finger from sides like this. Your visual acuity should be normal. You have to wear the specs if you have the specs. Patient has to wear the specs if he has the specs, right? Then you have to check for the fields from all the fields, from lateral, both sides, from upper to inner, from upper to inner. Ask the patient when he sees the field, and normal angles of the field you should know. I think it is 70, 60, 60, 80, right? Oh, 80, 60, 60, 70, like that. It is like that. Okay? This is the pathway, and according to the pathway, blindness, lesions. These are usually as causes of bitemporal hemianopia. So you should know optic chiasm, quadrilateral, quadrantonic, upper or lower. So you should know right hemiblindness or left hemiblindness. Then it is before the optic chiasm, one side, right? Another thing, in that RAPD, afferent pupillary defect, that is also important question, right? Grade 3, 4 and 6. First you see for the inspection of the eye, like size of the palpebral fissure, ptosis if visibly apparent, pupil, meiosis, mydriasis, right? Then pupillary reflex is light reflex, accommodation reflex. Light reflex, direct and consensual, you have to measure. How to measure? You have to see. Direct is when you see by torch in the same eye. Consensual is the response in the other eye, which is not being lighted, right? Then accommodation reflex, it is just you have to see bringing the object nearby, and there is convergence and meiosis. Now pathways you should know for credit marks. Ocular movements. Ocular movements you have to check in all the quadrants, like keep your finger at 30 centimeter, right? And 1 feet only. 1 feet, then you have to move right, left, up, down, all the corners, this, like this and like this. Your finger only. You can keep white wisp of cotton or red pin, red headed pin. Red is more sensitive, right? But finger is okay in the exam. And don't move more than 30-degree angle. If you move more and keep it persistent there, you will provoke nystagmus. You have to just move 30 degrees out in upper downward layer. Okay? So you should know what is diplopia, types of diplopia, nystagmus, some types of nystagmus you should know. Strabismus means squint. This is the picture where you can see third nerve palsy, fourth nerve palsy and sixth nerve palsy, right? Remember the formula we always use, SO4LR6 thrice, right? Yes, and you have to know which muscle moves eye where. So abduction is done by what? Lateral rectus. Adduction is done by medial rectus. Internal rotation, external rotation, upper superior rectus will lift it above, inferior rectus will lift it downwards, right? So down and out, ptosis and pupillary dilatation, classic third nerve palsy. Trochlear nerve, it will keep the eye in extrusion, and lateral rectus palsy, abducens nerve. That is lateral rectus palsy. So nystagmus will be provoked when you look to the palsy side face, right? Some questions of ophthalmoplegia. Supranuclear, internuclear, infranuclear. Infranuclear means all lower motor neuron palsies, what I showed you, third, fourth and sixth nerves. Supranuclear lesions, causes you should know. Internuclear lesions, causes you should know. Trigeminal nerve, you have parts, sensory, motor, reflexes. Sensory part is division wise, ophthalmic, maxillary and mandibular. Motor examination, Muscles, temporalis, masseter, pterygoids, tensor tympani, tensor palatii, right? You should know the names. Temporalis, you should know how to check. Pterygoids, you should know how to check. They expect this much. Tensor tympani, tensor palatii, we don't expect. Masseter, you should know. Reflexes, corneal, conjunctival, jaw jerk. Those I will be demonstrating in the video. Trigeminal nerve pathway, right? You should know the branches and the divisions. Facial nerve, that is very commonly asked. Parts, inspection, you just look for facial symmetry, movements and eye blinking. Motor part of the facial nerve means all the muscles of the facial nerve. So, raise the eyebrows, wrinkle the forehead, close eyes tightly, show the teeth, blow out cheeks against closed mouth, pause the mouth, whistle. Everything you have to ask the patient to do, and if he is not able to do, like for example, blow out cheek against closed mouth, if he tries to blow out the cheek air from the closed mouth, if seventh nerve is lesion is there on the left side, if I'm doing this, I will not be able to retain air on this side. It will be coming out like blow from this side. There will be drooling of saliva from the same side, right? Seventh sensory part, taste, sensation, anterior 2/3. That I will be telling you how to examine, like put all the taste, sugar, sour, salt and chloroquine tablet water you have to bring. Like a secretory part, lacrimation, salivation. For lacrimation we have test, Schirmer's test, nasolacrimal reflex. Reflexes, corneal, stapedial, glabellar are the seventh nerve reflexes. All the reflexes, conjunctival, corneals, ये सब, fifth is afferent, seventh is efferent. So they will come in both nerves, right? This is the pathway. Pathway you have to know to localize the lesion, because seventh nerve palsy has various lesions, level of lesions. If it is before genu, if it is after genu, if it is after nerve to stapedius, hyperacusis will not be present. If it is before genu, you will have other nervous intermediates entirely is gone, sensory, motor and the parasympathetic taste fibers. So everything is lost at the level of nervous intermediates. After genu, lacrimation is preserved, right? Greater now comes out at the genu. Then now to stapedius after genu, then cauda tympani. So after now to stapedius, only salivation is gone and the facial sensations, functions of muscle functions, right? These levels are important. Silence. So what does facial nerve supply? Sensation from external auditory meatus, taste from anterior 2/3 of the tongue, lacrimation, salivation, all muscles of facial expression and scalp except levator barbaris superioris, and other muscles, stapedius and platysma. Bell's phenomenon you should know, Bell's palsy you should know. Bell's palsy, whether it Bell's palsy is LM and facial palsy. Then we have to differentiate between UMN and LM and facial palsy. So upper part of the face is paired in UMN because it is bilaterally represented in the cortex, right? So better is upper motor neuron. LMN, everything is lost on the same side, right? Then localization, as I said, is important. Everything from the nervous intermediates, from the cerebellopontine angle to the facial muscle branches, everything is LMN, and there can be different diseases which causes different level of lesions. Vestibulocochlear part, auditory part, watch test, rubbing the finger and thumb or human voice, whispered sound, 3 feet distance you have to keep. If it is not heard, 3 feet whispered sound is not heard, means you suspect deafness. Then you go for Rennes-Weber's. Rennes-Weber's is to differentiate between bone conduction and air conduction. Matlab, it is nerve deafness or conduction deafness, you have to discriminate and know from Weber's and Rennes interpretation, right? You use 510 Hertz for tuning fork and other audiometric tests. Just know the names. You cannot perform at the bedside. Vestibular part, caloric test, rotation test, oculocephalic reflex or Dolzai reflex, fistula sign, vertigo. What is vertigo and some causes of vertigo you should know. Bedside you can only perform Bell's eye reflex and oculocephalic reflex, right? So might be asked, very rarely asked, this 8th now. 9 and 10, palate uvula gag reflex and larynx movement. So everything, just ask the patient to open the mouth, say ah, and see for the movement of palate and uvula. If there is palsy, one side will not move, and there will be curtain movement of the pharynx, there will be deviation of the uvula, everything will be on the normal side because the other side is not moving. The uvula is in the center and both side has to push it. So if this side is not pushing, this side is pushing, then it is normal side. So it will be pushing to pulling it. So this is not normal. This is abnormal. It is not pushing it, right? Any change in speech and voice, nasal twang you can expect in 9 and 10 nerves. Then know the pathways and branches. Trapezius, spinal accessory, sternocleidomastoid. Both movements I have written here. Test by it. First normally, then give some resistance. Hypoglossal nerve. Intrinsic tongue muscles, geniohyoid, right? Inspection, just see the size. It may be very small in atrophied tongue or very hypertrophied in some cases. Fasciculation sticks. Fasciculations is seen in non-protruded tongue and tremors of the tongue are seen in protruded tongue. Just do that. Protrusion you have to do to look tremors, deviation and apparent deviation. Same, if it is lesion is on the same side, that side will not work and the other side will pull it. So if the tongue is deviating on the left, the right side is not working. Percussion myotonia, one of the methods of percussion myotonia is to percuss on the tongue. Difference between bulbar and pseudobulbar palsy, that is a question, credit question for you. Sensory, superficial sensation, pain, touch, temperature, deep sensations, pressure, joint position, vibration. Cortical sensations, tactile localization, stereognosis, 2-point discrimination and graphesthesia. You should know everything. Tactile localization means point, symmetrically one point you have to touch, and with closed eye of the patient, asked him where did I touch. So he should know where you touched. Stereognosis, give a coin or key on the hand of the patient, close his eyes, then give and tell him to recognize the object. So that is stereognosis. 2-point discrimination, give stimulation at 2 points with some distance, and then in all the areas, like you can check for face, lips, hands, back and lower limbs. Barabar? You have to keep increasing the distance until the patient can know that it is 2 points. Start with the minimum, then increase. Graphesthesia, write something on the palm of the hand like 8 or 3 or A, B with closed eyes. He should be able to recognize what you have written, but patient should be literate. If he is not literate, just draw a circle and ask what did I draw. He should know it is a circle, right? These are the different types of sensory abnormalities. Brown-Séquard, hemiplegia, right? Thalamic lesion, lateral medullary lesion, saddle anesthesia, spinal level we can see cervical lesion, peripheral neuropathies, glove and stocking type. What should you have in your CNS kit? Right, this and stethoscope. Only thing missing here is stethoscope. Everything here you have it for your CNS examination. Chalo. Thank you, and I believe efforts will bring you better marks than your luck, so best of efforts. One video, 10 minutes, right?
So now I hope કે CNS માં at least અહીંયા જે ભણાવ્યું છે એટલું તો તમે બોલશો એક્ઝામ માં, હે ને? કે નહીં? In the exam we expect even the basic things you should know. બહુ ડિટેલ CNS માં તમને ના આવડે, it's okay, but the basics you must know. તો at least એટલું તો વાંચવાનું, okay?
કોણ લઈને આવ્યું? સોનાલી દીદી લઈને આવ્યા બધું?
તો હું અહીંયા એક્ઝામ
અરે યાર, પાક્કા પ્રોફેસર આપણા જેવું ને પેલું? ના મારા જેવું, તમારા જેવું ને? હું ને હેમાંગ છે પેલા હાફ હાર્ટ એટલે તમારા વખાણ મારા માટે સાકાર
અવાજ કરજો થોડો થશે. અહીંયા તો ફૂલ બતાવે છે. ચાલશે, કોઈ જોવાનું છે, થઈ શકતો હોય તો કરો. બાકી જોવાનું છે.
તારો મોબાઈલ છે ને એના માટે જ
મોબાઈલ આમાં ચાલુ છે ને પણ
એમાંથી વિડીયો નહીં આવતો. અહીંયા સ્પીકર
તમે અત્યારે તો પછી તમે આવો
પછી એમનું
પછી પાસ થવા મેં અંદરની પકડી
this is finger abduction and adduction. All the root values are also mentioned. ફોટો લીધો, ફોટો બધાને લઈ બધાને લેજો. યસ In this method, just don't hold very tightly. You have to give only light support. This is just asking whether you can feel this. Then you start doing on all the sides. You have to go dermatome wise. That you can see here. Keep we have that takani thing, right? Pin. Keep that with you for this thing. And don't poke with the sharp side. Poke with the other side. Right? Or he will be all bloody all over and he will just flee away from your exam. The patient. We don't want that. बस લોઅર લેવલનો નથી બતાવતી, આમાં બધું છે ને સેન્સેશન ને વાઇબ્રેશન ને બધું જ છે, એટલે આ ખાલી પતી જાય. લોઅર લેવલ નથી બતાવતા.
આપણે ક્યાં અહીંયા મૂકીએ છીએ.
એ ખાલી એને કહેવા માટે હતું કે આવું ફીલ થશે. Vibration you have to start from the most distal joint because dorsal column is a long tract and it depends on the length dependent abnormality. So first it will be abnormal in the distal most part of the body. So you have to go from distal to proximal. Kya sudhi loss hai, up to where the loss of joint position is there or vibration is there, that you have to see. You will find the level there. This is done, right? Bas done. Payment.
નો પ્રોબ્લેમ.
લોઅર લિમ્બ નું નથી બતાવતી હોમવર્ક.
કહી દેવાનું.
So what blunder you will make is when an examiner will ask to do perform joint position sense or vibration sense, don't start with upper limb. That is what I am focusing on. Start with the lower limb, great toe. Done. Done. Lower limb homework. See the video. Thank you. Madam, tomorrow.
ચાલુ કરો. So, after CVS and CNS, what do you expect? So, what do you expect? Yes? Case. Okay. Let us start with the GI system examination, okay? More marks, but easier. જેના નસીબમાં GI સિસ્ટમ એક્ઝામિનેશન આવી જાય, GI નો કેસ આવે, લકી. CVS આવે, અરે રે, રેસ્પી વચ્ચે આવે. Am I right? Okay. શું થયું, બ્રેક છે કે એક્ઝોસ્ટ થઈ ગયા? CVS CNS બસ saturated? GI system examination 1. हाँ start कर. I hope those who are leaving, they will do better. Okay. We will learn main points, starting from the symptomatology also, because when you speak the history after the chief complaints, you people make many mistakes in narrating the ODP. Okay. So let us start with the chief complaints of the GI system. What are these? તમે તો બોલો. It will be more interactive rather than just only teaching on the slides. You people have much more better access than me for the slides, videos and everything. And we have to give the exam orally, not on the slides and not on the videos. Okay? So what are the symptoms? Most important is abdominal pain and second is abdominal distension. So you should know what are the causes of abdominal pain. But how to narrate? What are the points you should remember? Whether it is acute or chronic, which site of the abdomen is involved, okay, what is the character of the pain, whether it is colicky, whether it is dull, diffuse, sharp, knife-like, whatever the character of the pain is there. What is the relation with the food? Whether it is relieved after taking the food or it is relieved after vomiting or it increases after taking the food. Then what are the other aggravating factors? Okay, any positional variation is there or not, and the associated complaints. If the vomiting is associated with the fever and abdominal pain, then it may be an acute gastroenteritis or enteric fever, it may be an infective hepatitis, and many more. So let us learn. Abdominal pain, acute or chronic, the site, which quadrant of the abdomen is involved. Can you name me the 9 quadrants of the abdomen? Anyone? So after 2 days the exam is there. So what are the 9 quadrants of the abdomen? Yes? Voluntary, or I should ask someone? Yes, you. What are the 9 quadrants of the abdomen in which we will examine? Yes, yes. I know you people know. It's not hypogastric. See, starting from the right side, we always stand on the right side of the patient when we are examining. Okay. So starting from the right side, it is in right hypochondrium. Then there is in right lumbar, right iliac fossa. This is an epigastrium, left hypochondrium, left lumbar, left iliac fossa, epigastrium, umbilical and hypogastrium. Where we demarcate? Now how demarcate? Okay, midclavicular line, the highest point of the iliac crest and the D10 level. Okay. Why we demarcate? Because the organs which are predominantly lying beneath these quadrants, and if the pain is there, any pathology is there, then these quadrants we can find the organ which is affected. Okay. So abdominal pain, again acute or chronic, the site, which quadrant of the abdomen is involved, what is the character? Burning, usually because of the gastritis, burning, epigastric pain, hyperacidity, you all people know. Dull and diffuse, whenever the patient of ascites is there, dull and diffuse, stretching like of pain is there because of the stretching of the abdominal muscle, because of the collection of the fluid. Then localized, if there is an hepatitis, the pain will be in the right hypochondrium. If there is appendicitis, the pain will be more in the right iliac fossa. And colicky abdominal pain. આપણે ગુજરાતીમાં I hope all people are well versed with Gujarati. Am I right? Okay. So what is colic? ગુજરાતીમાં શું કહેવાય? ચૂંક આવે. Okay. So what is the colic? So what are the 3 colics you know in the abdomen? Intestinal colic, renal colic, the pain which is in the patients of renal calculi. It is severe excruciating pain, and what is the main character of this renal colic? It radiates from loin to groin. Okay. And the third colic is biliary colic. So these are the 3 colics of the abdomen. What is the relation to the meal? Peptic ulcer, immediately after taking the food there is a pain, burning pain. In duodenal ulcer, after 1 to 2 hours. Eating disorders, you all are knowing, it's a short question in the theory. 5 mark, 10 mark. Anorexia nervosa, bulimia nervosa. And if the pain is after taking heavy amount of the fatty food, then what can be the cause? Pancreatitis. Okay. Radiation to the other site. Appendicitis, initially the pain may be in the epigastrium and then there is in the right iliac fossa. Pancreatitis, again the epigastrium is also involved. And cholecystitis, the referred pain may be to the shoulder. Associated complaints can give you the clue for the disease. Now, what are the non-GI causes of abdominal pain, where the GI system is absolutely normal? તમને પેશન્ટ આવે, પેશન્ટ કે બહુ જ પેટમાં દુખે છે પણ તમને જીઆઈ સિસ્ટમ તો બધી નોર્મલ લાગે, સોનોગ્રાફી કરાવો, એક્સરે કરાવો, બધું નોર્મલ છે. So you should ask about the comorbid conditions. If there is history of diabetes, diabetic ketoacidosis commonly presents only with the 2 complaints, that is an vomiting and abdominal pain. Acidosis may or may not be there. Okay. Then inferior wall myocardial infarction, that is also one of the cause for the epigastric pain. Many doctors, many students miss the diagnosis of myocardial infarction. So whenever the patient comes to you with epigastric pain, if the patient is middle to old age, take the ECG, exclude the myocardial infarction. Porphyria and lead poisoning. These are the non-GI causes of abdominal pain. Second symptom is vomiting. Again, acute or chronic onset you should know. What is the frequency? 2 to 3 times and 8 to 10 times. What is the difference? Why we need to ask? For checking the signs of dehydration. Okay? If the vomiting is more, then dehydration is there. Profuse or not, whatever is ingested is out. But profuse vomiting without nausea, usually vomiting precedes nausea. Nausea is what? Feeling of vomiting sensation. So, if there is a profuse vomiting without nausea, it is called projectile vomiting. Okay? This is a question you are asked. Projectile vomiting occurs because of two conditions. One is raised intracranial tension. Okay? Because of any cause. When there is raised intracranial tension because of any neurological pathology. And second is pyloric obstruction. Ask about the history of drugs. Drugs, ઘણા બધાને એવું થાય ક્લોરોક્વિન લે, કોમન સાઇડ ઇફેક્ટ. બધાને ફાર્મેકમાં પૂછીએ, ટેબલ પર પૂછીએ સાઇડ ઇફેક્ટ ઓફ ડ્રગ એટલે પહેલા એવું જ બોલે વોમિટિંગ. So most is chloroquine, aspirin and NSAIDs. These are causing gastritis. Comorbidities you have to ask for the vomiting. I narrated initially that DK presents with the vomiting and abdominal pain. Motion sickness history, many people may have. It also produces the vomiting. Migraine attacks is also there with the vomiting. And if we do not find the cause, it may be of psychiatric origin. Diarrhea. In chief complaint, many of you narrate that patient is having history of diarrhea. No. How to write? It's an increased frequency of stool, not a diarrhea. It's not layman terminology. We narrate the history in patient's language. So frequency of stool is increased. Acute chronic diarrhea. Again, chronic diarrhea more than 6 weeks. Most important cause is HIV infection. Second is tuberculosis. Third is malabsorption syndromes, inflammatory bowel disease, and if patient complains that after taking food I have to go, then it may be an irritable bowel syndrome. Okay. Dysphagia is difficulty in swallowing and it occurs in patients having stomatitis, esophageal candidiasis. It is also one of the early sign to suspect the HIV infection in the patient. Malignancy of the esophagus and esophagitis. Important thing, ascites, distension of abdomen. Okay. So, what are the causes of distension of abdomen? The mnemonic is 4F. 4F is fat, fluid, fetus and flatus. Pau na bola exam માં. તમને એક્ઝામિનર એમ પૂછે what are the causes of abdominal distension એટલે તમે એવું બોલો fat, fluid, fetus, fetus એવું નહીં. You have to say the abdominal distension occurs because of the ascites, because of obesity, because of pregnancy, because of intestinal obstruction, like this. Okay. So speak like this. Then jaundice, again bluish discoloration of yellowish discoloration of the sclera. How to check? Madam ભણાવશે તમને jaundice હે ને general examination બાકી છે. Okay. Then when you mention in the history, see you most of the time we put the case of the alcoholic liver disease. Patient will have mainly the 3 complaints: yellow sclera, yellow urine and abdominal distension. Fourth one may not be there or may be there, that is an edema of the feet. Okay. Hematomasis is what? Hematomasis is what? Yes, you white t-shirt. Yes, yes, stand up, no problem. What is hematemesis? Yes, very good. So blood in the vomit is hematemesis. Another one, blood in the sputum is hemoptysis. So how to differentiate? With the food particles. Okay. So hematemesis, again the etiology in patients of ascites is bleeding esophageal varices. Okay. Most common cause in the patients of ascites, because of the portal hypertension, the lower esophageal junction, there is dilatation of the vessels and it may bleed, that is an esophageal varices. Other causes are malignancy of the stomach, bleeding peptic ulcer, even in severe gastritis and malarious tear. The other symptoms in the GI system are regurgitation of the food, flatulence, dysuria, increased frequency of urine if patient is having urinary tract infection, urgency, hematuria also sometime if there is associated renal calculi, etc. Never ever forget to inspect. In inspection I will again repeat, never ever forget to inspect the hernial site, back and spine. You have to speak the hernial sites are normal and back and spine is normal. Okay. We have already discussed the 9 quadrants of the abdomen, but the important line is last. Never ever forget to flex the limbs before starting GI system examination. This is a common mistake you people do. Okay? તમને એમ કે ચલો બતાવો હિસ્ટ્રી બોલી રહ્યો ચલો બતાવો આ બતાવો તો સીધા પેશન્ટ સૂતું હોય સીધા હાથ મૂકો. You demonstrated the sign which is asked nicely, but you have not flexed the legs. So never ever forget. So what are the points to be seen in the inspection? Shape of the abdomen. Usually you people have a case which is having globular abdomen. Umbilicus examination. Movements with the respiration. Abdominothoracic, thoracoabdominal. Dilated veins, whether they are around the umbilicus or in the flanks. Skin over the abdomen. Localized dilatation or localized swelling is there or not. If there is organomegaly, then there may be a swelling in the right hypochondrium. If splenomegaly, left hypochondrium. Scar, if present, usually patient will have a scar of tapping of the fluid, ascitic fluid tapping of scar. Pigmentation means what? Bolo. Yes? Pigmentation have you seen the pigmentation over the skin of the abdomen? What is linea nigra? What is linea alba? What are the stria? Multiparous female and patient who are having an repeated ascites, alcoholic liver disease patient will have an repeated ascites. So because of the repeated stretching of the skin, the subcutaneous tissue will be fibrosed and the stria will be there. Okay? Divarication of recti. You all forget. Divarication of recti must be checked. કેવી રીતે જોવાનું એ તમને બતાવો. Hernial site, cuff impulse and inspection of the back and spine. Starting, say I am given a case of ascites, suppose, and I am going to start to speak about the inspection. So I will, by my history and general examination, I would like to go for the GI system examination first. Oral cavity examination is normal. See, our mouth gives clue to the many diseases. You will learn in the general examination. Okay? Shape of abdomen. It is globular because my patient is of ascites. Normally, shape of abdomen is flat with some little bit bulge is there in the lower abdomen. Globular is in ascites, obesity, intestinal obstruction, pregnancy. But in ascites, initially there is flank fullness. Okay? These flanks are full. So, when you narrate the history, in ODP, abdominal distension is there. Initially, it was in the flanks and then involvement of the whole abdomen has occurred. Lower abdominal bulge is usually seen below the umbilicus. The structure, full bladder, initial stage of pregnancy, initial stages of the ovarian malignancy, okay, or any pelvic pathology. Localized bulging in the organomegaly. What is scaphoid abdomen? Scaphoid bone, you people know, anatomy, boat shaped. So scaphoid abdomen is found. Upper coastal borders are visible, abdomen is hollow, and lower the pubic bone is there. Okay, so scaphoid abdomen is found in patients of the severe cachexia. Cachexia is what? Yes, anyone, please. Yes, yes, you. What is cachexia? Severe wasting. Yes, there is skin and bone. There is no muscle mass at all. There is severe nutritional problem. So cachexia and severe dehydration also. Okay. Second important part, shape of abdomen is globular. We have told. Then umbilicus examination. So umbilicus normally is midway between the pubic tubercle and the subcostal angle. Note about the abnormality, whether it is everted. Everted means अंबार आई गई है, protuberant. So it suggests umbilical hernia. Smiling umbilicus. Smiling is what? Because of the ascites, sometimes in the obesity, the umbilicus is transversely stretched. That is called smiling umbilicus. Okay. If the distension is because of the large ovarian tumor or because of the pelvic pathology, the umbilicus is never transversely stretched. It is vertically stretched. Okay. And one again, the terminology is crying umbilicus. It's a credit question. So what is crying umbilicus? Usually we do not found in general clinics. It is a patent foramen, and which patent urachus, the urine is dribbling from the umbilicus. That is called crying umbilicus. Oh, if some examiner asks you, bluish discoloration, emergency. If bluish discoloration you found around the umbilicus, that is called McCullen sign. And if this bluish discoloration is in the flanks, it is called Gray Turner sign. Now tell me, what are the causes? Why it's an emergency? Acute pancreatitis, not only pancreatitis, બધા pancreatitis કેટલા બધા જોયા આપણે કે એમને bluish discoloration થાય. Acute hemorrhagic pancreatitis. Okay. In female, it is important if there is ruptured ectopic pregnancy, that is why it's a medical emergency. Okay. And in patient who are having history of abdominal trauma, the splenic tear, it can also produce this bluish discoloration around the flanks or around the umbilicus. Again, umbilicus, see for the veins. Okay. Dilated veins in patients of the portal hypertension around the umbilicus. See, this is the umbilicus, and here the dilated tortuous veins are seen. These are called caput medusae. Okay. The history is written in the book. So if it is there, you have to narrate that the dilated veins around the umbilicus is seen. You have to also see for the flow, but it will come in the palpation, because in inspection we do not touch the patient. And if dilated veins are there in the flanks, you have also speak. Sister Joseph nodule, what is it? Yes. So around the umbilicus, the lymph nodes are there, and because of the underlying malignancy of the abdomen, if the lymph nodes are affected, then because of the metastasis, these lymph nodes are swollen and you may feel it. That is why these are called the Sister Joseph nodule around the umbilicus only. બીજે બધે ક્યાંય હોય તો એને Sister Joseph nodule ના કહેવાય. Okay. So this is about the umbilicus. So in umbilicus we have to see where it is protuberant or not, smiling, vertically stretched or not, what is the skin around the umbilicus, dilated veins are there or not. If protuberant umbilicus is there, check for the cough impulse also. Okay, patient ને cough કરાવવાનું કહેશું ને વધારે protrude થશે. Then movements of the abdomen. You people know male માં કેવું respiration હોય? Abdominothoracic. ને female માં thoracoabdominal. But when ascites occurs, In male, it reverses. Okay. So abdominothoracic in male, but in disease it becomes mainly thoracic, and thoracoabdominal in female. The movements of the abdomen in respiration is restricted if there is peritonitis. Look for the scar, skin, stria, peristalsis visible very rarely. It is mentioned in the book, but it is very rarely. In intestinal obstruction, strap ladder, in book you will read. Divarication of recti, never forget. How to see? Yes, how to check for the divarication of recti in inspection? Your patient is lying in the bed. The limbs are flexed. Okay, now ask the patient to straighten the limb. And straight limbs, ask the patient to elevate. And see the abdomen. If the center of the abdomen, this center of the abdomen bulge like this, triangular, then there is a divarication of recti because of the weak abdominal muscles. These muscles are weak because of the repeated pregnancy, because of the recurrent ascites. Then the divarication of recti is present. તમને bulge extra દેખાશે midline માં. આખું મોટું. Hernial sites again you have to check. Back and spine normal. So this completes your inspection. So what you have learned in inspection? The shape of abdomen is globular. We are taking the case of ascites. Shape of abdomen is globular. The umbilicus is everted. With the umbilical hernia, cuff impulse is present. The skin around the umbilicus is normal. Dilated veins are seen over the flanks. And there is no undue bulging, no skin, scar or sinuses. Back and spine normal. Divarication of recti is present. So these are the points in inspection. Okay. So let's move to the palpation. Palpation, rub your hand, warm your hand, and then ask the patient that I am going to examine you. Flex the limb, start the palpation. Palpation superficial and deep palpation. Okay. Slide करता समझो વધારે સારું. Superficial palpation, you have to start from the right iliac fossa, gently, જોરથી દબાવવાનું નથી. બરાબર? Gently press and feel. Look to the patient's face, whether there is any pain is present or not. તરત જ face ઉપર response આવે. Temperature તો તમે અડો એટલે જ ખબર પડી જાય. So look for the temperature, tenderness, rebound tenderness. Okay. So moving in the anti-clockwise fashion, all quadrants of the abdomen must be examined. And look for the temperature, tenderness if present in the quadrant, the underlying organ is affected. Deep palpation. Deep palpation includes the palpation of the liver, palpation of spleen, palpation of kidney. Sometimes, if you are asked, it's a credit, palpation of gallbladder. And direction of the flow in the dilated veins. That is Harvey's sign. H-A-R-V-E-Y, Harvey's sign. So superficial palpation with the pads of the fingers, gentle touch in anti-clock manner from the right iliac fossa, temperature, tenderness. What is rebound tenderness? Now tell me. What is rebound tenderness? Yes, anyone? Raise your finger, raise your hand. Or I suggest. Yes, first bench. What is rebound tenderness? You tell us.
When we press upon the sides, then patient feels the pain.
No. We press and patient feels the pain, that isn't tenderness. What happens in the rebound? Why the name is given rebound? That when we press gently, there is no pain at all. But when we release our hand, there is pain. That is rebound tenderness. Okay? Okay. And rebound tenderness indicates what? Inflamed peritoneum. Underlying peritoneum is inflamed. Then, rigidity and guarding. So when you palpate, ઘણા પેશન્ટ તો એવા જ હશે આમ ખાલી હાથ મૂકશો ને એટલે બૂમો પાડે. બરાબર? So we should know whether actually the abdominal pain is there or not. So rigidity is voluntary. પેટ એકદમ કડક કરી કાઢે અને guarding is involuntary. and it is always a pathological condition. So if patient is having an pain, જ્યાં બી હાથ મૂકો ને બૂમો પાડે તો તમારે એને થોડું રિલેક્સ કરવાનું, અશ્યોર કરો. Ask him to take deep breath and then palpate the abdomen. If guarding is there, it suggests there is an hollow viscous perforation underlying and there is severe peritonitis. Okay. Deep palpation, palpation of viscera, liver, spleen, kidney. Many methods you all people know. Many methods are given in your books. Conventional or classic method we use routinely. Second is dipping method in the patients of ascites. Hooking method is there for the liver. Okay. And kidney, bimanual palpation. Let us learn. I told you credit question, palpation of gallbladder. At the level of 9th costal cartilage, in the mid-clavicular line, just palpate. If patient says there is a pain, then there is an acute cholecystitis. And if you feel the gallbladder and there is jaundice, then it is said, it's a Cardiovascular's law. It is again a credit question. Cardiovascular's law, it says what? If the palpable gallbladder is there along with the jaundice, it suggests that there is underlying gallbladder malignancy. Okay? Okay? Cardiovascular's law. Last bench. So palpation of liver. કેવી રીતે કરશું? કોઈ એક જણ આવી જાવ ને પાછળથી, વોલન્ટિયર. અરે આવો આવો યાર, તમારી જે એક્ઝામ છે તમારા જ કલીગ છે. ચલો ચલો, તું આવી જા ભાઈ, ચાલ. અરે તું વ્હાઈટ શર્ટ, વ્હાઈટ ટી શર્ટ, યાર તું જ આવી જા ને યાર, ચાલશે. આવી જા.
Suppose he is supine. Okay. Change that flag. You have to erase it. So naturally important as teaching just only because that you people make the mistakes in anxiety, even if you know you are giving in the wrong way. Okay. So for the conventional method, the classical method, starting from writing your fossa, you have to palpate gently, feel with the border. Ask the patient to take deep inspiration and expiration and move your hand at least 1 to 2 centimeters gradually upwards. Starting from the right iliac fossa, we will move gradually upwards and our hand should be parallel to the right coastal border. Never ask the okay, right coastal border parallel and feel whether the angle is there or not. Okay? Okay? Well, that is theoretical importance. Practically, that is modern enough for you people. But in the books, it is also given you have to notice about the consistency, notice about the border, whether it is sharp, whether it is rounded. There are crucial topics. Second, spleen examination. Spleen examination, you have to start again from the right iliac fossa. Why? Because spleen is the section, liver enlarges like this. So we can feel like this. But spleen enlarges into this manner. Spleen enlarges towards the umbilical. And that is why we have to palpate from the right iliac fossa gradually and feel whether the spleen is palpable or not. Okay? What we need bimanual palpation. One hand, left hand, will be standing on the right. Okay. Renal angle. And the other one is in the kidney cavity. Lumbar tissue. What we will do? અહીંયા થી ખાલી પાછળ કરવાનું છે, પાછળથી સ્લો આપવાનો. renal angle ને લેવાનું છે. Okay. It is gentle thrust and if kidney is enlarged, then there will be here. Okay. તમે એનામાં બધાથી kidney palpate થાય છે. Okay. Yes.
Sarja. So palpation of liver is by conventional method from the right iliac fossa. ડીપિંગ મેથડ છે ને બે રીતે બધા કરે. ઘણા એક્ઝામિનર એવું હોય એક જ હાથથી કરો. એટલે શું કરવાનું? ડીપિંગ મેથડમાં અસાઇટિસ હોય, હાથ તમારો જેમ છે એમ જ મૂકો. યુ પુટ યોર હેન્ડ with the tip of the finger, displace the fluid and then feel the viscera. This is also that with this hand you will displace the fluid and with this hand you will feel the visceromegaly if it is there. Okay, you got? So dipping method is there in the for performance of the checking of hepatomegaly in ascites. Hooking method from the head end, and with the right hand you have to hook your fingers in the right hypochondrium and the costal border for mild or minimal hepatomegaly. If it is there, with the deep inspiration you can feel, otherwise it's okay. What are the causes of hepatomegaly? ચલો બોલો 1 2 3 4 5. એક્ઝામ 2 દિવસ પછી છે જ. બોલો બોલો. હિપેટોમેગાલી ના કોઝિસ તો બોલો. માઇલ્ડ મોડરેટ સિવિયર અલગ પાડીને નથી પૂછતી હું તમને, બધું ભેગું જ પૂછું છું. તો વાંચો. હે કાલા આઝાર, હિમેટોલોજીકલ મેલિગ્નન્સી લાઇક લ્યુકેમિયા, લિમ્ફોમા, amoebic hepatitis, congestive liver disease. There are many causes. Note about the tenderness, surface, granular or nodular, border, whether it is sharp or rounded. Granular હોય તો cirrhosis of liver હોય, nodular હોય તો hepatic malignancy હોય, sharp border હોય તો hepatitis હોય, rounded border હોય તો congestive hepatitis હોય. So it's okay. Consistency of the liver, firm કે normal. Palpation of spleen again. How to do? I demonstrated conventional method, dipping method, and sometimes minimal splenomegaly in the right lateral position, but we are not doing it. Okay, in the ascites. Causes of splenomegaly again: soft tender splenomegaly in enteric fever, tropical splenomegaly, malaria, kala azar, portal hypertension, most important your case, and many more. Most with the what are the characteristics? कोई examiner છે જૂનું બધું પૂછે. How to differentiate between the spleen and the kidney. Okay, how to differentiate? Book માં આપ્યું છે how to differentiate. So it moves with the respiration, it moves to the RIF, it enlarges. Fingers cannot be inserted between the spleen and the costal border. The border, anterior border of the spleen is notched, there are notches, and there is no ballotment. Ballotment એટલે આમથી આમ કરીએ feel થાય, that is ballotment. Okay. Grading of splenomegaly, clinical grading is different. We use this Hackett's classification. Okay, grade 0 to grade 5. Normal impalpable spleen, grade 1 is spleen palpable only on deep inspiration. Grade 2 spleen is palpable on mid-clavicular line halfway between the umbilicus and costal border. Grade 3 spleen expands towards the umbilicus more. Mid-clavicular line ની આગળ જતી રહે પણ umbilicus સુધી નહીં પહોંચી. પછી up to the umbilicus અને પછી beyond umbilicus. Okay. Kidney palpation bimanually. I narrated one hand in the lumbar region, other in renal angle. Give a mild push with the same hand and feel with the hand in the lumbar region. Palpation of any other lump after kidney. બીજે ક્યાંય તમને એબ્ડોમેનમાં કોઈ લિમ્પ ફીલ થાય તો કહેવાનું. Measurement of the distance from the umbilicus to the xiphisternum and umbilicus to the pubic symphysis. Why it is important? To differentiate whether abdominal distension is because of the ascites or because of the pelvic pathology. If the distance above is more, then it is ascites. If the distance below is more, it's a pelvic pathology, large ovarian tumor. Because shifting dullness can be there in the large ovarian cyst. Liver, then the percussion. Percussion માં આપણને મેઇન વસ્તુ તો ascites ની સાઇન જ છે. Organ percussion, okay. Liver percussion. Liver dullness is found in fifth intercostal space in mid-clavicular line. Percuss કરતા કરતા જાઓ જ્યાં સુધી liver dullness આવે. Mid-clavicular line માં measurement લો. That is in liver span. બરાબર? That is called liver span. Splenic percussion, there are various methods. Nixon method, this. Okay. Trough space. Trough space ખબર છે તમને શું છે? Semilunar space bounded by ટ્રાઉ સ્પેસમાં કેવો નોટ આવે પરકસ કરીએ તો ટિમ્પેનિક કેમ air in fundus of the stomach. Okay. Kidney percussion required if kidney is palpable only then. Signs of free fluid in the abdomen. ચલો કહો કઈ કઈ છે બોલો મિનિમલ એસાઇટિસ હોય તો શું આવે પડલ સાઇન એનાથી થોડું ફ્લુડ વધે તો શું આવે શિફ્ટિંગ ડલનેસ એનાથી ફ્લુડ વધે તો શું આવે હોર્સશુ ડલનેસ ને ટેન્સ એસાઇટિસ હોય તો શું આવે ફ્લુડ થ્રિલ ઓકે so here one tympani is there why the fluid is collected according to the gravity okay sitting માં નહીં supine માં એટલે ઉપર જ્યાં આવે ત્યાં બધું intestine fluid થતા હોય so at that area you will get the tympanic note on percussion કરવાનું કેવી રીતે આ તમારી finger it should be attached with the skin this is the pleximeter and this is the plexor okay either this or this whatever you are convenient movement should be free it is at the rest and the stroke should be given at least 2 to 3 times and note the sound which occurs so horseshoe dullness second is fullness in the flanks third figure is shifting dullness I will demonstrate fluid thrill how to check and this is puddle sign in genu elbow position genu elbow એટલે knee elbow position patient supine હોય ત્યારે percuss કરો umbilicus ની around that is a resonant note when you ask the patient to assume the knee elbow position wait for some time the fluid is collected there around the umbilicus because of the gravity again percuss there is a dull note shifting dullness માં શું કરવાનું okay which is the pathognomic of all this horseshoe dullness okay that is the pathognomic of ascites or the signs of free fluid in the abdomen shifting dullness can be absent if there are fibrotic bands in the fluid હોય પણ fibrotic band થઈ જાય એટલે shifting dullness is absent and fluid thrill is also found in the large ovarian cyst and sometimes in the polyhydramnios this is a shifting dullness what in the supine position the flanks are having a dullness start from the umbilicus gradually percuss towards the periphery note the point where the dullness is there keep your finger there remember keep your finger there ask the patient to assume the lateral position wait for at least 2 minutes and then again percuss that area now the area which was dull initially the fluid which was here has been shifted so this is here there will be a resonant note okay and this does not complete your shifting dullness again percuss to the area towards the umbilicus and the area which was resonant now became dull so the dullness which was present here has been shifted to here that is why this sign the name is given shifting dullness this completes your shifting dullness એવું નહીં કે તમે આમ કરતા કરતા આયા ડલ આવ્યું પેશન્ટને સુવડાવ્યું હવે સર આ રેઝોનન્ટ થઈ ગયું this is incomplete okay so complete shifting dullness is there in some book also again you have to ask the patient to supine position again and percuss again then also it is shifting dullness but shifting dullness is there never ever leave your finger till you are complete your examination this is horseshoe dullness the fluid is collected all way it is the name given because the dullness area assumes the shape of the horseshoe that is why the horseshoe dullness is there starting from the umbilicus go towards the periphery all side in all direction mark the point of the dullness draw the line so below which the dullness is there fluid thrill how to check ask the patient to keep his hand over the center of the abdomen limbs are flexed put your one hand to the side in the flanks and with the other hand not sharp stroke a gentle stroke is given to produce the vibratory wave which passes through the fluid and feel this wave here okay Why we keep this? Why we keep the hand midway? To prevent the vibratory waves to pass from the skin and subcutaneous tissue. It should pass only through the fluid. So that is about the fluid thrill. Okay. Puddle sign, shifting dullness, horseshoe dullness and a fluid thrill. Okay. Last part, auscultation. GI માં સ્ટેથો લઈને જ જવાનું. Peristalsis. Put the stetho gently over the abdomen. Wait for at least 1 or 2 minutes. You will be able to hear the peristaltic sound. Usually the peristaltic sounds are 5 to 8 per minute. If a large peristaltic sound is heard, even without the stetho, it is called borborygmi. It is seen in the intestinal obstruction. If peristalsis are low or not heard at all for 1 or 2 minutes, then that is an paralytic alias. It is a common finding post-operatively. Gradually there is recovery. And in patients of the hypokalemia. Okay. So this completes your GI system examination. Bruit. What is bruit? તમે ભણ્યા હશો કેરોટિડ બ્રુઈ એટલે શું કરવાનું કેરોટિડ આર્ટરી ઉપર સ્ટેથો જેન્ટલી મૂકવાનું અને સાંભળવાનું અ friction sound is heard. Okay. The same thing, the hepatic bruit is also there in patients of the hepatoma on the right hypochondriac. Very rarely, I have also not ever heard about the hepatic bruit. Renal bruit is common. Okay. In the horizontal line, just 1 to 2 centimeter away, both the side. Here is the umbilicus, both the side. Renal bifurcation, renal artery originates. So at that point, if there is renal artery stenosis, the renal bruit is auscultated. And rarely venous hum, uterine shuffle, etc., etc., etc. Per rectal examination is given in your book, but we do not expect in exam. Okay. Not in medicine. Surgery in khabar nahi. So this completes your GI system examination. Okay. Again, history examination bolo, oral cavity examination is normal. On inspection, this. On palpation, no organomegaly. And on percussion, the signs of free fluid in the abdomen. જે હોય એ જ બોલવાની, બધી નહીં બોલવાની. એક જ પેશન્ટમાં બધી સાઇન ના આવે. બરાબર હે ને એટલે તમે એવું જ કરો પડલ સાઇન પ્રેઝન્ટ છે શિફ્ટિંગ ડલનેસ પ્રેઝન્ટ છે ફ્લુઇડ થ્રિલ પ્રેઝન્ટ છે હોર્શુ ડલનેસ પ્રેઝન્ટ છે હોર્શુ શિફ્ટિંગ મે બી ધેર ઓકે so now we will move again short case then we will take long case okay general examination બીજો important part. I would like to welcome Dr. Brinda Madam to take your general examination. Sorry. થોડી વાર તો બેસો. So these people have arranged some sort of felicitation for us. Okay.
Thank you, Dr. Sangeeta, for such an enriching lesson. सबको समझ आया, बहुत मजा आया होगा, right? I invite Dr. Brinda ma'am.
ભલે લેક્ચર પછી સાંભળજો તાળીઓ પાડો યાર Dr. Sonali madam. Sorry. On behalf of Dr. Sonali madam, Dr. Hemang sir will receive. આવવાની? Okay, sorry. એ આવવાના છે પછી પાછા. મને એમ કે ગઈ સાહેબ. મને એમ કે ગઈ. ના ના એને કોઈ હું આવું છું કઈ ન ગઈ છે. ડોક્ટર ધ્વની મેડમ. તમારા એક્સરે ઇસીજી ધ્વની મેડમ શીખવાડવાના છે. જોજો બરાબર. હા ભાઈ એક્સરે માં પ્લુરલ ઇફ્યુઝન હોય તો કહેવાનું સાહેબ ખબર નહીં શું દેખાય છે. કોન્સોલિડેશન છે, એબનોર્માલિટી છે નથી, બાર એક્સપર્ટને પૂછવાનું આમાં શું છે, આમાં શું છે, કેવો એક્સરે છે, શું નામ લખેલું છે પેશન્ટમાં. ડોક્ટર હેમાંગ સુથાર સર ઇઝ ધેર. અઘરો કેસ પણ બહુ સરસ રીતે સાહેબે શીખવાડ્યું હે ને. બધા ભગવાનને પ્રાર્થના કરે એક્ઝામની બહાર ભગવાન મને સિરિયસ ના આવે. સાહેબે એ જ અઘરી વસ્તુ તમને બહુ સરસ રીતે શીખવાડી. ડોક્ટર ઇબ્રાહિમ મોમિન સર, he is also going to take the table viva. અહીંયા જ ટેબલ વાયવા લેવાના બધાના. So okay, if you want to take a 5-minute break. કાં તો પછી ભાઈબંધને ફ્રેન્ડને કહી દો કંઈક ખાવાનું લેતા આવે બેઠા બેઠા. ગ્લુકોઝ તો જોઈએ ને.
On behalf of Ahmedabad Medical Association and all the students, all the faculties, I extremely thank you. Thank you for giving time and so much knowledge and guidance to the students. And hope everyone is enjoying and please come back soon after having tea.
ચા રાખી છે?
हाँ मैम, अंदर करवा दूँ आपके लिए?
અમારો તો
अंदर भिजवा दूँ मैम यहाँ पे? आप सब
કોફી હોય તો મેડમ કોફી બી કોફી મોકલાવજો ને.
વાત સાંભળો પણ સાંભળો
ચાર ચા ને એક કોફી. તમારું કયું છે તમારું? ભારત કે ચાર